Hi guys, I am Dr. Ramakrishna Chaitanya, consultant anesthesiologist, critical care physician and a faculty of anesthesia at Marrow. So basically today in this session, I would like to discuss the recent recall questions from the INISET examination from the anesthesia point of view. So as you have seen this question paper, you have written this examination and you are aware that this question paper is not tough. Most of the questions what we have discussed in our video lectures or from our Q bank that have been repeated. The one thing is the questions are slightly trickier side. So when the question paper is on trickier side, you should have a thorough conceptual knowledge in order to crack this kind of examination. This can be an indication for the forthcoming examination that the question paper is going to be more trickier. More emphasis is made on the clinical based or clinical approached MCQs. So what I will do, as you know, the anesthesia questions, they are not so many, there are only few questions. So I'd like to keep this session very short for you, so that I would like to discuss in detail about the anesthesia questions. Some questions might be, they can be mixed with some other branches. So in those kind of questions, I will quickly review those things. I will not go into the details of it. Also, I would like to talk about few points about the oxygen therapy in COVID patients, because there was one question in this recent INISET examination. And also, I would like to talk about the changes in the BLS and ACLS algorithms, because there were two MCQs that came from this examination. Okay, so we'll just begin this session. Okay, the first question, the position of the patient that is shown in the image is. So the options were A. Trendler-Burr position, B. Reverse Trendler-Burr position, C. Lloyd-Davis position, D. Jackknife position. So basically this is a pretty straightforward MCQ for you. So you might be knowing this answer. The answer is very clear. That's a reverse Trendler-Burr position. So, sir, this is not an anesthesia related question, sir. Why are you discussing this? So, I'd like to tell here, because when a patient is under surgery, when a surgeon is doing surgery, the position of the patient plays a very vital role. Because with the position, when a patient is under anesthesia, all the reflexes are blunted here. So when the reflexes are blunted, there can be chances with the change in the position of the patient, there can be chances that he might go into hypotension or he might go into hypertension. There can be chances of increased ICP, etc. So that's the reason why I would like to discuss here. Okay, I will not talk about the positions and the type of surgeries where you are using, but from the anesthetic point of view, might be because, if some question has asked in the before examination, like I said, might be the related question, there can be chances that they can ask something which is related to it in the coming next examination. Right? So what is this? There are so many, second slide. So there are so many surgical positions that are there. You might be seeing in this slide that, the supine position, Trendler-Burr position, lithotomy position, reverse Trendler-Burr position. So many positions are there. So what is the classical MCQ that has been asked many times in your AIIMS examination? What is the position that is very common for venous air embolism? The answer is very clear. You might be knowing it. That is the sitting position. That is the sitting position where there are chances of venous air embolism. So what, according to anesthesia, this was also asked in AIIMS examination. So where do we use this sitting position? So before talking about all these position, when I am talking about position of a patient under anesthesia, the four things which come into my mind is the name of the position, the where it is used or which surgeries it is used. The third one is the physiological changes that occur during the change in the position of the patient, the complications associated with it. Right? The first position, I'll quickly review it. I'll not go into the details of it. Might be surgical faculties have discussed in detail about this. So I'll just quickly review it. Right? The first position is the supine position, which is very commonly used for GI surgeries. Most of the GI surgeries like hernia, hydrocele, whatever, right? They can be used. So what are the physiological effects of this supine position? So the physiological effects are when you make a patient lie down, the FRC, that is the functional residual capacity, will be decreased. So there can be chances of hypoxia. There can be, when not really hypoxia, when the functional residual capacity is decreased, we all know that the closing capacity will increase. Right? So there can be chances that the alveoli will collapse. alveoli will collapse, and there can be chances of hypoxia will be there. So what we do under anesthesia is we will mitigate this effect by using some amount of PEEP. Even in general anesthesia also we use small amount of PEEP for the patients, or we increase the oxygen flow rates to minimum of 33% under general anesthesia. Right. What are the complications that are associated? Basically, supine position is not associated with that much amount of complication. But yes, when you don't properly align the patient, there can be chances of complications. On prolonged lying down, on prolonged duration of lying down patient in supine position, there can be chances of pressure alopecia on the scalp, or sometimes, the patient arms will be hyperabducted. There can be abduction greater than 90 degrees. Surgeons might be while doing the operation, rather than keeping the arms like this, they will be stretching the arms something like this. This can lead to compression, nerve compressions. And when you keep the patient in supine position, the forearms should be supinated and flexed. The forearm should be supinated and flexed, because if you pronate the arm, what will happen is there can be chances of ulnar nerve compression. Ulnar nerve compression, and the patients in the post-operative period, they complain about tingling and numbness in the areas where the ulnar nerve is distributed. So, this is not a big problem in our country, but in foreign countries, they might sue you. When a patient is having tingling and numbness, or when a patient is having neuroparaxia in the post-operative period, they might sue you. So this is a very, very important medico-legal complications that can be associated with the positioning. So as I said if you have listened to my videos, the regular videos in the edition 4, the first thing in the first slide I said during a patient under anesthesia, what I will do there is I will monitor the patient vitals, I will monitor the patient position, I will monitor the patient blood loss. Because if there is a change, because surgeon is busy in doing the surgeries, so my job is to look at the position. So there should not be any nerve compression leading to neuroparaxia or weakness, etc. Right? So this is the first position what we have discussed, that is the supine position. The second position, the lithotomy position. You all know that most of the urological procedures and gynecological procedures are done in this lithotomy position. When I keep the patient in lithotomy position, one thing is very important. How do we keep the patient in lithotomy position? You should lift the patient legs simultaneously, both at a time, not one by one, both at a time, and it should be flexed at the hips and at the knees. And the stirrups that what we use, the stirrups, it should be placed properly, right? So when you lift the legs, what will happen to the preload of the heart? Obviously when you lift the legs, because there are no receptors, they are blunted under anesthesia, there can be chances of increased preload. There can be chances of increased preload to the patient, right? So you should lift both the legs simultaneously at a time. And when you keep the patient in lithotomy position, what are the associated complications you can anticipate? There can be chances of compartment syndrome in the leg, because if you don't place the stirrups properly, and very commonly there can be nerve compressions. And the most common nerve that is compressed in a patient when he is kept in this lithotomy position is the common peroneal nerve. The common peroneal nerve, which is encircling the fibula head, it can be compressed and it can lead to lost foot drop in the post-operative period. Or sometimes the saphenous nerve, which is coming near the medial condyle of the tibia. Or sometimes, when you flex the hip joints along with external rotation, there can be chances of compression of the sciatic nerve also. So you should be very, very careful. You should keep the patient under anesthesia. You should change the position very gently. Right? So this is the second position, that is lithotomy position. There can be variants in this position. Like, the patient can be kept in lithotomy position as well as in Trendelenburg position. So what is this Trendelenburg position? We'll talk in the next slide, right? The third one, which now this has been asked in your examination, there's a reverse Trendelenburg position. Most of the times the upper abdominal surgeries like laparoscopic cholecystectomy, this is the commonly used position. So what is the physiological effect of it? So the physiological effect is the patient is in head up position. So there can be chances of hypotension. And the good point about this position is this is the position where you can have a good or maximal amount of FRC. So when I am recovering a patient from anesthesia, I will keep the patient in slightly head up, 15 to 30 degrees of head up will be kept. slightly head up position of 15 to 30 degrees will be kept. So the complications, you should be very careful about causes of hypotension, because a patient with having underlying cardiac problem cannot tolerate that much amount of hypotension also. The other position is Trendelenburg position. As I said Trendelenburg position is an opposite of reverse Trendelenburg. The head will be in the lower side. Most of the urological, gynecological procedures along with lithotomy, as I said they will be kept in the Trendelenburg position. So here in this position, what will happen, the head down position will reduce because the abdominal contents will be pushing my lungs. It reduces the FRC. Simultaneously, with this lithotomy position, there can be chances of increased preload. Right? So these are all the effects you should be understanding when a patient is kept in position. And when you keep the patient in head down position, there can be chances of increased intraocular pressure as well as increased intracranial pressure. And on prolonged keeping, because some surgeries the duration might extend up to 4 to 5 to 6 hours also, there can be facial edema can also be seen. So why I am talking about all these positions is, in any of these position change under anesthesia, there can be chances that my endotracheal tube will come out or it will be pushed inside. So when it is pushed inside, it will go to endobronchial intubation and the saturation will be falling down. Or when it is pulled out, again the saturation will be falling down. So how do I identify the change in the the dislocation of the endotracheal tube? By looking at the capnograph. That's the reason why we discussed in detail about capnograph in the anesthesia video module. Right? So this is the other position, Trendelenburg position. The other position what we are going to discuss now is prone position. So where it is used? Most of the times prone position is used for spinal surgeries. Of late we are using it for posterior fossa surgeries also. Actually, ideally speaking, posterior fossa surgeries, they are preferably done under sitting position. Because it gives, at posterior fossa means this is the position where they are doing the surgeries, and this was the question that was asked in AIMS examination. So when this sitting position, this gives an adequate surgical view for the surgeon. But the biggest problem with sitting position is there are chances of venous air embolism, so which is a very dreadful complication under anesthesia. Which is because you are in a sitting position. What will happen? All the veins, the blood in the veins will be drawn out, and the pressure, the veins will be in a collapsed state. So if you accidentally give a nick to the vein, the air will be sucked into this venous system, and from the venous system it directly enters into the heart, into the internal jugular vein and to the heart, and it leads to the sudden cardiac arrest. Right? So this position, from surgeon's point of view, sitting position might be a good option, but from anesthetic point of view, it might not be a good option for us, because we need to be very, very vigilant in identifying the venous air embolism. So most of the times what we do is, preferably if not sitting position, if the patient is high risk for venous air embolism, what we do is we generally keep it in a prone position also. When we keep a patient in prone position, so we use bolsters. Bolsters are like pillows. Right? So where do we keep these bolsters or pillows? One should be kept on the chest wall. The second should not be on abdominal wall. It should be on the pelvic cavity. The abdomen should be free, because if you compress the abdomen, it will again push the abdominal contents above and it will reduce my lung compliance. It will reduce my lung compliance. When a spine surgeon is doing surgeries, it increases the bleeding because of venous engorgement, because of compression of the abdominal cavity. Right? So abdomen should always be kept. The bolsters should be kept, one on the thoracic cavity, the second one should be on the pelvic cavity. Again, when I keep the patient in prone position, there can be chances of extubation, accidental extubation, and very, very important MCQ is there can be chances of post-operative visual loss. You should be very, very careful when you are keeping in a prone position, because you can compress the eyes. So it's a very, very important medico-legal issue also. Right? So this is the prone position. Right? The next one is the lateral position. So most of the times we use lateral position for thoracotomies. There is slight modification of lateral position, that is a kidney position also we use for kidney surgeries. Most of the times the pyelolithotomies and all these, we use a left lateral position, right? So what is the physiological effect of the lateral position? A very important MCQ here in the lateral position is there will be profound, the maximal amount of VQ mismatch, that is ventilation perfusion mismatch will be there in this lateral position. Why? Because when a patient is in lateral position, now this is the lower portion is the lower hemithorax, the upper portion is the upper hemithorax. The lower hemithorax, what will happen, it will have maximum amount of pulmonary blood flow due to gravity. The upper portion will have maximum amount of ventilation. So it's not like, you might be reading about V by Q ratios in a normal patient in your physiology, but under anesthesia in left lateral position, you should never keep a patient in spontaneous respiration. You should always use positive pressure ventilation, because there will be maximum amount of ventricular perfusion mismatch can occur. Right? So when you keep the patient in left lateral position, you should take all measures to prevent the complications like axillary nerve compression, because you will be keeping the patient in this position and there can be chances of axillary nerve compression, and the head and neck should be in a straight uniform line. Head and neck should be in a straight uniform line. Right? So this is about the few positions that have been asked, and the one question that has been asked, which I have been telling you, is which position is most common for venous air embolism? That is the sitting position. I have purposefully not discussed it, but one question I would like to emphasize here. A patient is done under a posterior fossa surgery. This was asked in your entrance examination. A patient was scheduled for a posterior fossa surgery under sitting position. During the surgery, the patient suddenly had a decreased EtCO2. EtCO2 curve was suddenly came down to 0. What could be the chance of it? So obviously you can answer it. A patient in sitting position when the surgery is going out. So when you change the position, understand this logic. When you change the position, you look at the EtCO2. Suddenly there is a drop in EtCO2. That means the endotracheal tube is displaced. When you change the position, EtCO2 is normal. But during the surgery, when the EtCO2 became 0, that means this is a case, and the position is very much favorable for venous air embolism. So this question has been asked in the AIIMS examination. So read the question properly. That's what I wanted to emphasize. During the change and this position, the sitting position during the surgery is very pro that there are chances of venous air embolism. And how do we identify venous air embolism? By looking at the EtCO2. And I have discussed in detail about the venous air embolism in the chapter of in edition 4 in anesthesia for neurosurgeries. It's a very important MCQ. Please, if you have not watched that video, please have a look at that video. That will give you more insight into the venous air embolism. So this is about the first question, positioning of the patient, right? We'll go to the second question. Next slide. That is the identify this equipment. This is a new question to you, might be. But those who are working in COVID wards, those who are working in COVID ICUs, this is not a new question. This is a straightforward MCQ for them. Why? Because this question, this is one equipment which I have been using in the last 6 months. I have used it many times. So what is this equipment? Identify this equipment. Many students complain that the image quality is not good, but you have to adjust. We don't have any other option, because many students have messaged me saying that sir, in Marrow you give us a good quality image, but in examination the image, we need to adjust our spectacles to watch these images. We don't have that option, but you have to adjust with this examination pattern. We don't have any other option, right? So coming to this image, so what is this image? So a mechanical ventilator without a monitor. So obviously it's not looking like, it's not a mechanical ventilator. Those who have seen a ventilator, he will definitely rule out this option. Infusion pump, yes, if you have attended a clinical posting, you can easily rule out. Infusion pump is very small, this much. It will be around hardly around arm's breadth, right? This is not an option. CPAP machine, obviously you might have seen this CPAP machine, those who are used for obstructive sleep apnea. This is also not looking like it. The last option is high flow nasal cannula. Yes, this is the right answer. High flow nasal cannula. This is the right answer. And this, as I said we have been using it very recently in the COVID patients. That's the reason why they have kept it. Clinical emphasis has been given. So what is this high flow nasal cannula? Quickly I will add few words about it, because I have not covered about high flow nasal cannula in the regular videos, because I was not using this one in my routine clinical practice. Only in these last 6 months we have been using this. So what do you mean by high flow nasal cannula? So we all know nasal cannula, it consists of two prongs that is used. Right? What do you mean by high flow? So high flow means, imagine you are a person who is taking around a tidal volume of 500 ml, right? And you are breathing at a rate of 12 breaths per minute. That means your minute ventilation is around 6 liters per minute, right? Suppose you are slightly dyspneic, your respiratory rate is increased to 20, right? Your tidal volume is 500 ml. So how much is your minute ventilation? It increased to 10 liters. Right? So in mild dyspneic patient, when the respiratory rate is between 20 to 30, right, your minute ventilation will be somewhere around 10 to 15 liters per minute, approximately. I am not very good at maths, right? So 10 to 15 liters per minute. So what do you mean by high flow nasal cannula is, with this machine will provide gases more than your minute ventilation. So this machine is basically used in patients with mild dyspnea in COVID patients. So what is the biggest advantage of this machine is, the studies have proven that using high flow nasal cannula or non-invasive ventilation early in a patients with COVID, we can avoid intubation. Why? Because in these 6 months, whomever I have intubated, 97 or 99% of the patients have not come out of ventilator. So it's very, might be ventilator might be looking very, very lucrative options in COVID patient, but the mortality rates when a patient lands upon ventilator is very, very high. So we tried, and this putting a patient on ventilator and giving him ventilatory care in COVID ICUs with COVID patients is very, very Herculean task, because there can be chances of aerosol generation. It can infect me, it can infect my healthcare workers and all these things. So what we generally do is, in all COVID patients who is having respiratory distress, in the initial stages only, we start on with oxygen therapy. Either with the help of high flow nasal cannula or non-invasive ventilation. Remember, very important, both these therapy it requires, these are also aerosol generating procedures, but not as high as endotracheal intubation or suctioning. But yes, you need to have a proper universal precautions in the form of PPE, N95 mask, hazmat suit and all these things, you should be wearing it. Right? So this is a very, very important point of view. So how to set this machine? If you look at this machine, the points, this is a very simple machine. It looks very complicated, but it has only few parts that is associated with it. One is humidifier. The other one is nasal cannula, a heated circuit and a glass blender. How to set this machine? There are only 3 things that you need to set this in this machine. The first one is you need to set the flows. The second one is you need to set the percentage of FiO2. The third one is you need to set the temperature of the patient. You need to set the temperature. So the flows, the FiO2 and the temperature. Now, sir, what is this flows? What is this high flows? What is the advantage of it? So you might be knowing, right? So when we are using nasal cannula, most of the times we use a flow rate between 1 to 6 liters per minute. Most of the times in clinical practice, I use around 2 to 3 liters or 4 liters, but you can go maximum up to 6 liters. You cannot go more than 6 liters. Why? Because, the gases what we are supplying through the nasal cannula, they are dry gases. They affect my mucociliary function, and it will be very, very distressful for the patient who is already dyspneic to supply dry gases at a very high flow rates to the patient. So what we generally do is, these high flow HFNC machine, we have an option to set it around 40 liters per minute, 60 liters per minute, and some machines, I have not seen this machine, but we also have a machine where we can set around 120 liters per minute also. right? So most of the times we use around 40 to 60 liters of setting of the machine, and when we are supplying that much amount of flows to your upper airways, all precautions should be taken that the air is humidified, otherwise it will destroy or it will affect the mucociliary function. The second important thing is, when we set the flow rates depending on the patient's respiratory rate, we approximately calculate the minute ventilation and we approximately set the flow rates, and we keep the FiO2 around, we start around 100%, we slowly come down and we titrate it to maintain a saturation greater than 94%, not more, not 100%. We always try to maintain around 92 to 94 is okay for me. I will not look at it like 98, 99%. Anything more than 92 to 94, I am happy with it. Right? One thing is very important. When a patient is kept on HFNC machine, a very important thing is his mouth should be closed. Why his mouth should be closed? Because it has been shown that because of that much amount of oxygen that is present in your upper airways, the patient, whatever the oxygen he is taking, he is getting 100% oxygen. And when you close the mouth, there will have some amount of CPAP effect. And it will have some amount of CPAP effect on your lower alveoli. So it's a very important thing. So you need to train to the patient. And some patients, we use intermittently HFNC machine along with NIV machine also, non-invasive ventilation in the form of CPAP, etc., to provide oxygenation. Right? So in these patients, so how to set this machine? We adjust the flow rates of the patient, we adjust the FiO2, we adjust the temperature. Most of the times we keep the temperature around 37 degrees centigrade. Right. Now the third point, how to approach a patient with dyspnea, who is having dyspnea in COVID patient. Only 3 points you need to understand. Mild to moderate cases. The first thing is positioning of the patient. So when a patient is having mild to moderate dyspnea, studies have proven that keeping a patient in prone position will help in oxygenation. Why? Because the alveoli that are present in the dorsal segment, they are compressed. So when you keep a patient awake, proning is recommended to prevent or to improve the oxygenation in the patients with mild dyspnea. Right? So why, sir, why not in prone position? Why? Because you might be assuming the lungs are a homogeneous structure. No, lungs are heterogeneous structure, and when you keep in the prone position, because the weight of mediastinum and the heart, where they will distribute in such a way that the ventral position alveoli will not be compressed that much amount like in dorsal position. So awake proning is very important. And when a patient who is on mechanical ventilator, where I am unable to improve the saturation even after using high end, like maximum FiO2, maximum PEEP, maximum PIP, all these things also, PIP means peak inspiratory pressure. So then also I will use the patient in prone position. But it's a very cumbersome procedure to keep a patient in prone position. But yes, prone position has been proven to improve the oxygenation in patients with COVID, even in mild patients or in severe cases who is on ventilator. The second thing is oxygen supplementation. We'll talk about this oxygen supplementation in detail now. So as I told you in my videos, regular videos, the next slide, the black slide, right? So as I told you in the videos, the oxygen supplementation can be done by two ways. One is a variable performance devices and a fixed performance devices. So what are the examples of variable performance devices? The examples are, the first one, what you can see here, that is the nasal cannula. So nasal cannula, as I said, 1 to 6 liters per minute. As a general rule, how much amount of FiO2 it increases? For every 1 liter, the increase in FiO2 is 4%. For every 1 liter. So maximally, the nasal cannula, usage of nasal cannula will improve FiO2 from 24 to 44%. The second one, the simple face mask, what we have routinely seen in our casualties. So what they do is, you might have seen this simple face mask, which will have a side holes in it. Why there are side holes in this mask? They are called as variable performance devices, because when you use this, we use a flow rates around 5 to 10 liters per minute. So when we are using 5 to 10 liters per minute, so when the patient minute ventilation is on higher side, it will entrap some amount of atmospheric air. So it will entrap some amount of atmospheric air, and it will improve around 35 to 55%. Maximally, the numbers, you don't concentrate on the numbers, but yes, the numbers are the approximate values. So it can improve up to 35% to 55%. The third one is non-rebreather mask. This is very, very important. Non-rebreather mask is like a simple face mask, but it will have some amount of a bag on the lower side, where this bag, which when we are using the flow rates around 10 to 15 liters per minute, we should make sure that the bag is fully inflated. Right, when the bag is fully inflated, when the patient is taking the breath, it provides that 100% of oxygen in the next breath. Right, so it will improve the saturation, or it will improve the FiO2 to around 80 to 90%. So non-rebreathing mask is very, very important. Make sure that when we are using a non-rebreathing mask, the bag that is used, the reservoir bag that is used, is always inflated. If it is deflated, there is no point in it. The other one is a Venturi mask, which is like, it is a fixed performance device. So in all these above devices, like, nasal cannulas, simple face mask, non-rebreather mask, we cannot exactly tell how much percentage. It's an approximate value what we are trying to tell to you. But in a Venturi mask, it is like, you can see here, it is a color coded mask. We have already discussed it in detail about this in the video session. You can see this is an orange color or some red color, orange color plastic cannula type thing with side holes in it. So when you are trying to, everyone, like, if you want to increase FiO2 by 24%, you need to keep the flow rates around 2 liters per minute, and it is like pink color. Something like that, like 28%. Like, the color coding is not very important. It depends on manufacturer. So it is color coded. Simultaneously, when you keep that much amount of flows, because of that air entrapment, the FiO2 percentage will increase accordingly. Right, so this is a very important, these are the very important oxygen delivery devices what we use, and very recently that has been added is HFNC, where we can improve the oxygen concentration as a fixed performance only. We can improve, and we can, because there are so many factors when we are keeping a patient on HFNC. There are so many factors. The patient's mouth should be closed. We are doing a rough calculation of minute ventilation. Right, so there are so many factors that are there, but still it is a very good device that can be used in mild to moderate patients, in COVID patients. Right, so this is about this machine, high flow nasal cannula. Right, so one more important surrounding question which I would like to add upon, or I have shown this picture in my regular videos. Here I am not showing you because you have to take some effort, because you might see this picture and you might have forgotten this. But in my regular videos I have shown you one picture of oxygen concentrator. Again, this is very important. Of late we have been using in COVID patients, many COVID patients in home therapy, or even in some sub centers we have using this oxygen concentrators. In many patients we have using it. So please make sure, take out your time and energy to look at how the oxygen concentrator is. Right, I am not going to discuss about all this in detail here, because already I have talked about this oxygen concentrator in the section of machine, anesthesia machine, the sources of oxygen in the patient. The third thing is reassess the patient. In a patient with approach to a patient, the reassess the patient means, you need to set the targets. Like as I said, we keep a target of SpO2 92 to 94. We keep a target of carbon dioxide for some 55 to 60%, 60 mm of Hg. We keep a target and we reassess the patient constantly. Why we reassess the patient? This high flow nasal cannula, it doesn't have any inspiratory alarms. We can't set the tidal volume. We can't set the respiratory rate. So when the patient is having accumulation of carbon dioxide and he is becoming drowsy, so there can be chances. This machine is just providing the oxygen, but this will be effective if a patient is awake. right? So if the patient is becoming drowsy or if a patient is becoming unconscious, this will not be so much amount of effective to the patient. So we need to intubate to the patient. So high flow nasal cannula or non-invasive ventilation, the take home point is it is used only in patients with mild to moderate dyspneic patients and also who are awake, who are oriented, who are cooperative. If a patient is not cooperative, it will be very difficult. We need to train the patient, then only he can adjust and we can use this high flow nasal cannula machine. So this is about in detail about the high flow nasal cannula and also the oxygen delivery devices. Right. The third question, very common straightforward question. What is the size of cannula that is shown below? So might be they have given this image only, the pink color rough image. You all know what is the answer? The answer is 20 gauge. So there is a one classic mnemonic, one student has showed me this mnemonic. I found it very interesting. You all know this one, right? If you remember this picture, that will be fine enough. So the plant with a pink flower, sun, blue light, this image is self-explanatory. Interior portions of the earth, it is like red color, that is 14 gauge, red or orange color. On the soil, it is gray color, that is 16 gauge. 18 gauge is grass. 20 gauge is pink color flower, blue color is 22 gauge, 24 gauge is sun, that is the yellow color, 26 gauge where we use it in premature neonates, 26 gauge is violet. So most of the times when a patient is in hypovolemic shock, we prefer 16 gauge cannula because this is having wide bore and I can rapidly transfuse. Not central line. This has been asked many times. This is not a first time that has been asked. So superficially I am covering it up. So you all know this question, that is the sizes of the cannula. The fourth question, which is purely anesthesia related question. The blue pipeline in operation theatre is used in. Might be, they have not given the image. Might be the answer is nitrous oxide. They are asking something like this. Like this image, that's the next slide which I have been showing. The image what you are showing, they meant the blue pipeline because this is a recollected question. I am not sure what they have really asked about it. Most of the students said that the blue pipeline in OT. So obviously we have discussed it many times in the routine videos. The blue pipeline, blue is for blue Neela nitrous oxide. I have told you this one also. So let us quickly tell you, I will quickly tell you about the various colors of the cylinders. I will not tell you again whole story about it because we have discussed it in detail in edition 4 about the anesthesia machine segment. We have discussed types of cylinders, what are the various colors of the cylinders. Blue color cylinder or blue color pipeline is for nitrous oxide. The second one is oxygen cylinder is black body with white shoulders. Helium cylinder is brown color. Cyclopropane is orange color. Right? Cyclopropane is orange color. The third one is Entonox cylinder. That is half nitrous oxide. 50% nitrous oxide, 50% oxygen. That is blue and white. And air cylinder is opposite to that of oxygen cylinder. That is the white body with black shoulders. So these are the most commonly. And the black color cylinder is nitrogen. So these are most of out of all these things, what we commonly use is oxygen and nitrous oxide. So if you have seen your operation theatre and you are looking at these kind of pipelines on the walls of your operation theatre, make sure that what are the pipelines. Most of the times the blue pipelines indicate they are like nitrous oxide. So yellow, yes, yellow is here what you are seeing in this picture. Some places they keep it green. This is not exactly color coded, but most of the times we don't keep white because it will not be visible. Simple logic, that's it, right? But blue we specifically, because the cylinder of nitrous oxide is also blue and the pipeline is also blue in color. So might be this is the image what they are going to ask about you. So blue pipeline in operation theatre, the answer is very obvious, that is nitrous oxide. Right. The fifth question, the given set of instruments that are used. Very good question that have been asked. So the first one is central line insertion. So those who have seen, I have showed you the central line venous catheter set. I said you the technique that have been used in central line insertion is a Seldinger technique, where we have a syringe, where we have a guide wire, where we have a catheter. Can you see any of these things here? No. So obviously central line insertion is not there. Arterial line insertion we don't have a set. It's like a normal IV cannula set only. It's like a normal IV cannula set only. So obviously this is also not a option. Umbilical catheter set, you don't use that much amount of umbilical catheter insertion set. You don't use that much amount of equipments in a small baby. Obviously it is looking like you have some LMAs, you have airways, you have nasopharyngeal airways, you have laryngoscopes. What it can be? The answer is very clear. That is a airway management tray or a difficult airway cart, whatever it might be, right? So this is straightforward, pretty straightforward, purely anesthesia related. So this question, why I wanted to emphasize here is very important, is of late in the last 3 years, definitely one question is coming, 1 or 2 questions is coming from the airway management section. I have dealt in detail in the edition 4 videos about the airway management. Right, please, if you have not watched that section, please have a look at this edition, because last year also there was a question, before last year also there was a question on this edition for airway management section, right? So this is the very straightforward question, that is the airway management, right? The 6th question, as I was saying you, there were 2 questions in the CPR. So what I will do is, first I will read out the questions, later we will talk about the changes. I will not discuss about, the CPR guidelines and all, whole of guidelines, because, unless I show you, you will not remember it, right? So I'll just quickly read the question. First one, on your morning walk in the park, you noticed an unconscious man lying on the road. Which of the following options indicate the best next step? Right, very good. So if you have, you might have finished your final year MBBS, definitely you might have got certificate in the BLS, basic life support. As per, many colleges, they do give this basic life support training. So what is the first step you need to do when a patient is unconscious? Check for carotid pulse, observe, wait till the ambulance arrives, defibrillate, check for pulse, do CPR, check for carotid pulse, start CPR, call for help, defibrillate if no pulse, call for help, check pulse. So first thing, the options might be confusing. The answer is very clear. The first thing you need to do is call for help. Call for help. So look at these options. Out of 4 options, only option B has a call for help. The first thing you need to do is call for help. The second thing what you need to do is check the pulse. Which pulsation you will check? You will check for the carotid pulsation. Sir, carotid pulsation I am not able to check. Not only carotid, you can even check for femoral. Most of the time carotid is the accessible part. That's the reason why we check for carotid pulsation. In how many seconds? Less than 10 seconds. We'll try to palpate the carotid pulsation in less than 10 seconds. Suppose if the pulse is there, what will you do? You turn the patient to left lateral position and watch for the breathing. That's it. Suppose if there is no pulse, what will you do? You will start compressing the chest wall. Right? How much amount? You will keep around 100 to 120 per minute. 100 to 120 per minute. Right? And suppose by this time when you are doing the compressions, the help arrives and you attach the defibrillator or AED, automatic external defibrillator, you see that there is a rhythm which is of ventricular fibrillation. Ventricular fibrillation means the hand will be moving, like, the waveform will be moving like this, right? So what will you do? Immediately give the shock. So this is a basic algorithm. So very, very important, because I have been observing this trend. 2 questions are very standard in all patterns of examination. That is a question on airway management, a question on BLS and ACLS. If you have not read about these questions, please take out your time and read about these questions for the next coming examinations. Right? So what I will do here is, I will tell you the key changes, because it's not, if I start telling you about whole of the algorithms, I might be taking around 3 to 4 hours of your time. That's not, still it might not be effective, because unless I show you all the videos and demonstrations, you will not appreciate the change. So I will not tell you. It has been nicely asked in our Q bank. So please go through with the Q bank. What I will do here is, I will try to tell the key changes that have been made in 2020 guidelines about ACLS and BLS. Okay, so these guidelines have been changed 1 month back only. Not more, not very, it's only a it's a very recent pattern of the change. So the first change what they have said is the changes in BLS and ACLS. Just if you want to make a note also, please make a note of it. You might have seen in various social media the changes that have been made. So I'll try to explain very superficially for you so that you will not get confused, because many students have asked me, sir, can you explain in detail? Explaining in detail, there is not much difference in 2015 to 2020 guidelines. In 2020 guidelines, the first change what they have said is a sixth link to recovery is added to all 4 chains of survival. So if you look at the diagram, in the 2015 guidelines, there were only 4 chains of survival. In the first one, what you are seeing in this picture, the previous picture, that is early adult IHCA chain of survival. That is adult in hospital cardiac arrest chain of survival. The early recognition, activation of emergency response, high quality CPR, defibrillation. The 6th post cardiac arrest care. The 6th one what they have cared is recovery. They have made a special emphasis on the recovery part. Because many times you do CPR, you try to maintain, but you will get the rhythm, but the upper story would have been gone, because the blood supply to the brain might be jeopardized, and it can lead to a vegetative state in the patient. So in these recent guidelines, they have made a special emphasis on the recovery aspects of the patient. And in the adult outside hospital chain of arrest, activation of emergency response, this was asked. As I said, first thing you need to do is, in hospital you need to monitor. Out of the hospital, first thing is call 108. In our country 108, in other countries 911, right? High quality CPR, defibrillation, advanced resuscitation, by the time the call help comes, and the post cardiac arrest care and recovery. Right. So this time they have made a special emphasis on the recovery part. The second point, early emphasis on adrenaline therapy. So within 5 minutes of cardiac arrest, you should get, you might be thinking, sir, what does it happen in our country? Yes, in our country the things are changing. We are also having good amount of 108 services or ambulance services. So if you get a support in the form, when you call for the help, when you get a support, immediately try to give adrenaline as quickly as possible. Because there was one more question regarding adrenaline, I'll discuss about this. So how much amount of adrenaline? 1:10,000. 1:10,000. You have to take. How much amount of adrenaline is normally present? We'll talk about this adrenaline in the next question. Right. So the third point is EEG, neurological imaging, should be introduced in the part of post resuscitation care. As I said, most of the times we do CPR, we get the rhythm back. But what will happen in this process is the blood supply to the brain is decreased, and the patient would suffer from serious or severe hypoxic brain damage, which leads to a patient in a vegetative state. So what they have made an emphasis is, they said that EEG and neurological imaging should be done as a part of post resuscitation care. And in previous 2015, there was something called as FAS. FAS means facial drop, arm drift, speech difficulties in a patient with CVA. Now they have changed it to FAST. What does it mean? Facial drop, arm drift, speech difficulties, along with time to call an emergency number. That's it. So in a patient with suspected CVA, if you are having facial drop, arm drift, speech difficulty, you add one more P to it to make it a full algorithm, FAST, that is time to call an emergency number. And all patients are advised to take aspirin except in case of non-traumatic chest pain. So any patient with chest pain of more than 40 years of age, unless they have any contraindication, it is advised to give aspirin. And the ventilation rate in adults is 1 breath to every 6 seconds. Previously it was 5 to 6 seconds. Very small change, subtle change. If you notice, previously they used to change 5 to 6 seconds. Now they have made it very clearly only 6 seconds. That means how many breaths you are going to give in 1 minute? 6 seconds. That means 60. So 60 by 6. Approximately you will give around 10 breaths, not more than 10 breaths. Sir, why are you very much emphasizing on this 10 breaths? So if you hyperventilate the patient when you are doing this CPR, what will happen is the carbon dioxide will be washed out. When the carbon dioxide is washed out, the blood flow to your brain is decreased. As I said you in the neurosurgery segment, one of the strong determinant in a patient in the cerebral blood flow of the patient is carbon dioxide. When the team is doing the CPR, we need to give breath at one breath for every 6 seconds. Use of waveform capnography in recommended during bag mask ventilation also. Previously they used to say that capnography is used when we keep the advanced airway. But what they are now saying is use capnography even in patients when you are doing the bag mask ventilation also. And use of mobile technology is also reasonable, what they have said. Right? So these are the changes in BLS, basically in the BLS. So what about the ACLS? They said in the ACLS, the amiodarone and lignocaine, they are now considered as equivalent antiarrhythmic. So previously they used to say amiodarone should be given. Now they are saying that amiodarone is and lignocaine both are equal. And in symptomatic adult bradycardia, atropine dose has changed from 1 mg to 0.5 mg. Dopamine dose has changed from 2 to 20 micrograms to 5 to 20 micrograms. So please, if you have not looked at the ACLS algorithms, please have a look at the ACLS algorithms. Try to make your own notes, because these algorithms every year definitely one question is coming from it. So atropine dose in bradycardia has reduced from 1 mg to 2.5 mg, whereas the dopamine dose has increased from 2 to 20 to 5 to 20. And emphasis has been made to prevent hyperoxia, hypoxemia, hypotension. They said no increased oxygen, no decreased oxygen, or no decreased blood pressure also, because when the blood pressure also decreases, it will reduce the blood flow to the brain. Right? Initial stabilization split into the manage of airway, manage respiratory parameters, and manage hemodynamic parameters. For adult tachycardia, IV access and ECG moved into the earlier algorithm. So keep an IV access, all these things they have moved. Updated ACLS algorithms, ACS, acute coronary syndrome algorithm, contact to balloon inflation goal is less than or equivalent to 90 minutes. So the balloon to inflation goal is less than, when a patient is having, that means before he goes into the cath lab, it should be less than 90 minutes or equal to 90 minutes, right? The target SpO2, what they have said in a patient is SpO2 should be greater than 94% for stroke patient in general care and 92 to 98% in post cardiac arrest care. So you should maintain this good amount of oxygenation to the patient. And during CPR, 15 seconds before pausing the compression, high performance team should check for the pulse, pre-charge the defibrillator, prepare to deliver the shock within 10 seconds or less. To increase the CCF, what do you mean by CCF? It is chest compression fraction, right? Greater than 80%. Most of the times when we are doing this chest compression, so what will happen during a normal CPR is, so what the recent recommendation I said is, normally what happens is during when we are doing the chest compression, we will take a pause, we will check for the pulse, we will charge the defibrillator and we will give the shock. So there is a very good time gap is there in the chest compressions. So what they have said in the recent recommendations is, during CPR, when a team is doing the CPR, 15 seconds before pausing the compressions, okay, high performance team should check for the pulse. So when you are doing the CPR, the performance team should check for the pulse, pre-charge the defibrillator and prepare to deliver the shock. The moment you remove the hands on your chest, within 10 seconds, I need to give the shock. Because why? Because if all this goal, all these things what we are doing is to increase the chest compression fraction. So most of the times we might be doing an effective CPR in a patient, but if you give some amount of gap also, what will happen is there can be chances that the patient will go into that hypoxic brain damage. So all goals are made to improve the compression rate, because they said it has been proven a 10% increase in chest compression fraction will lead to 11% improvement in the survival of the patient. So very important, this is the changes that have been asked, and the few things that they have said is a feedback devices should be used as the mobile technology and all these things. Intravenous access is preferred over intraosseous route in children. a new diagram for neuroprognostication. It has been given very nicely in this. I have not kept this diagram because it will unnecessarily confuse you. So those who have not seen this neuroprognostication, nothing important about it. So how the recovery is going on, they are monitoring in the post-recovery care. And the newly introduced concepts in this CPR is CPR coach to help the team leader. CPR coach ensures high quality basic life support while the team leader focus on other aspects of ACLS. Previously we used to have only one team leader. Now we have one more team that is called as CPR coach. A double sequential defibrillation that has been recently introduced, in situ training, booster training, spaced. So this time they have given more emphasis on training and neuro monitoring. Training of the staff is very important. So these are all the new things that have been asked. So what is the changes that have been changes that have been done in BLS and ACLS in pregnancy? So quickly I will tell you that a separate algorithm for pregnant patients, those who have survived with our cardiac arrest during pregnancy, that they said that for perimortem cesarean section, if there is no ROSC, that means return of spontaneous circulation, you have to do the cesarean section within 4 minutes. Previously they used to say within 5 minutes, now they moved to 4 minutes. And in opioid related cardiac arrest, they say give naloxone. Previously they used to say consider naloxone. Slight change in the English language, that's it, right? And fetal monitoring is not required when you are doing maternal resuscitation. So when you are doing maternal resuscitation, you need to monitor, because our main goal is to see the mother should survive. If mother is not able to survive within 4 minutes, you have to go for cesarean section. Okay, and in post recovery in pregnant patients, turn the patient into the left lateral position, because the gravid uterus will compress the inferior vena cava and it will reduce the blood flow, right? So these are the changes that have been seen in pregnant patient. What are the changes in the pediatric age group? The rate of, you might be reading about this, but quick review I will tell about the pediatric age group also. The rate of breaths in pediatric age group has increased to 1 breath for every 2 to 3 seconds. It is 20 to 30 breaths per minute. Okay, and in children, 30 breaths in children less than 1 year, 25 breaths in greater than 1 year. Okay, so in pediatric age group, it is increased like 20 to 30 breaths per minute. If it is less than 1 year, 30 breaths per minute. If it is greater than 1 year, it is 25 breaths per minute. And umbilical vein catheterization to be considered. And very important change in pediatric is, in previously what we used to do is, in children we used to secure the airway with uncuffed airway, because the most narrowest part of the airway is the subglottic region. Right now we have something called as micro cuffed endotracheal tubes. So what they recommend in pediatric cardiac arrest is use micro cuffed endotracheal tubes, not routine cuffed. I am emphasizing it again, micro cuffed endotracheal tubes. And previously they used to say that use 2 fingers for compression. But now they are saying like encircling and doing the compression is better than 2 finger compression. And there is a new algorithm that has been introduced for pediatric tachycardia. So these are the changes that have been mentioned in the new CPR guidelines. Please, after listening to this, please compare it with 2015 or look at the new guidelines and algorithms, because they are very important for your entrance examination. Okay, we move on to the next question, the 7th question. Right? So match the following dilutions of adrenaline in various situations. So the first option they have given is 1:1000, 1:10,000. The third one is 1:1 lakh. The options they have given is the cardiac arrest, anaphylaxis, and local anesthesia. So for cardiac arrest, so already I have told you many times in the video also, I have told you that adrenaline, it is present in the form of a small ampule which contains 1 ml of adrenaline bitartrate, which is equivalent to 1 milligram of adrenaline, that has a dilution or concentration is 1:1000. So in all cardiac arrest situation, we give 1:10,000 dilution of adrenaline. So what we generally do in our clinical practice is we take out 1 ml of adrenaline, we dilute it to 9 ml, we dilute with 9 ml and make it into a 10 ml syringe, and we give 1 ml of adrenaline. We give 1 ml of adrenaline. So the dilution becomes 1:10,000. So by looking at the option, if you know one option rightly in this match the following type of MCQ, so cardiac arrest 1:10,000, that is B option answer is 1. Right? So if you look at the options very closely, the second option B is having the second option B is having one option. So obviously the answer is option B. Right? So it is very clear, straightforward MCQ, right? Cardiac arrest, if you know it, right? Sir, I don't know the cardiac arrest dilution. The second thing is, if you have entered into your clinical postings or in your, operation theaters or in casualties, the next slide, you might have seen a lignocaine. Here it is very clearly mentioned 1:2 lakh. So normally in our clinical practice in local anesthesia, what we do is we use a dilution of adrenaline in lignocaine at 1:2 lakhs. Sir, here but there is no 1:2 lakhs, sir. There is 1:1 lakh. Yes, most of the times that means, somewhere or other it is coordinating. 1:2 lakh is what we generally use because it contains 5 micrograms of adrenaline per ml. 5 micrograms of adrenaline per ml. So when we make it is 1:1 lakh concentration, it will become 10 micrograms per ml. Right? So mostly you can just by using logic also you can make it right. 1:1 lakh is in local anesthetics. So what is about 1:1000? I said it in the chapter of anaphylaxis that what we do is when a patient is not having an IV line, and we have a severe anaphylaxis in a patient, what we do is we take 0.5 ml of 1:1000 dilution of adrenaline and we give it subcutaneously. So this will also help. So obviously these three options, the questions we have discussed about cardiac arrest, we have discussed about local anesthetics in the chapter of local anesthesia. I said 1:2 lakh. Most of the times we use 1:2 lakh, but here he want to confuse you, the examiner. So instead of giving 1:2 lakh, or he might be feeling, the rhyming option 1:100, 1:1000, 1:10,000, 1:1 lakh. So might be, it's not a crime to use 1:1 lakh dilution also. So most of the times what we use is 1:2 lakh concentration, as you can see in this picture. 1:2 lakh concentration means it contains 5 microgram per ml. Right? So this is about the 7th question, the dilutions of adrenaline. And as I said if you know one scenario properly, you can answer this one also very easily. Like, the cardiac arrest, the basic life support, advanced cardiac life support, how much amount of adrenaline we use, you can answer this kind of MCQ also. It's a very straightforward question, right? The next question, effective CPR includes, this is again straightforward from the BLS and ACLS algorithms. So the first one, they said 20 to 24 per minute. They have not mentioned anywhere that it is an adult or pediatric. If they don't mention, generally what we consider it as adult only most of the times, unless they specifically mention pediatric or pregnant patient. So as just now I discussed, we don't give 20 to 24 breaths per minute because if we increase the breath rate, it will reduce my cerebral blood flow. Right? So the first option is ruled out. The second compression, chest compressions is between 100 to 120. Already I have discussed that whenever you start compression, we start compression. So B option is right. Allow the chest to recoil. This is very, very important. When you are doing an effective CPR, it should be a CPR. It should not be like, what we do like chapati or, just mashing up the duff or anything, right? So you have to give the chest compression and allow it to recoil. Then only the blood will flow. You will get some amount of blood into your heart. Right? So effective chest compressions not only include chest compression, allowing the time to recoil also. Right? So 5 to 6 centimeters of compression. So approximately we take around, most of the time, if you ask me, right option, the 5 centimeters compression is required, but only B and C options were not given. So we choose the option of B, C, D because chest compressions of 100 to 120 per minute, the allowing chest to recoil and a compression depth of 5 to 6 centimeters. Okay, so these are the 8 questions which are slightly mixed with some other branches also, but these are few questions that have been asked in your recent INISET examination. So one thing is very clear, that they are giving more emphasis on clinical based MCQs. So please make sure those who are doing internship, make sure you attend your internship postings religiously. Try to understand, try to look at the things what are happening around you. Right, now coming to the last segment of it, my views on the changes in the examination pattern, or at this moment we don't know what is the examination date. So most of you might be thinking, like most of you, not only like you are not unique. Many students have messaged me saying that sir, I kept an INISET as one benchmark. If I have secured like 3000 rank, 4000 rank, might be I have good chances of getting good score in NEET examination or next coming examination, right? So but unfortunately I got around 6000 rank, or I got around 7000 rank. I might be feeling like I didn't achieve it. Am I in the race? Am I doubting myself? Because I am very sure that this video would be watched by the students who has narrowly missed their goal, not the students who have secured the rank. I left those students, because once you have got the rank of 60, 70, 80, it's fine, 100, 200, it's fine. You will not watch this session. Those who have narrowly missed this session, I'm very sure that they would be watching it, and definitely I'm very sure that they might have kept this as a benchmark. Now you might be feeling slightly demoralizing, or you might have given so much amount of good effort for this examination INISET in this pandemic period. You have kept your best efforts in this INISET, but unfortunately what happened here is that you have not achieved your desired rank. You are feeling slightly depressed, like what it is shown in the slide. Right. So one thing I wanted to tell here, small thing, I am not very good at giving lectures on this kind of motivational, but one thing which I wanted to tell you, I was reading something and I found it interesting here. So the story of the day, what I call generally, because I like to tell a lot of stories to my students. So you look at this slide, one thing is very clear. The story is, when you look at the wild animals, out of which the lion, which is considered as the king of animals, in lions, out of all hunting process, only 25% of the times the hunting will be successful. That means 75% of the times the lion's hunting process are unsuccessful. In the lower group of animals like fishes, they lay around like hundreds of thousands or millions of eggs, but only few will come out and become fishes. And polar bears, which are very cute enough, half of the polar bears, they don't reach to puberty, they are died. This is half. If you look at the seeds, if you look at the plants in the surrounding world around you, 50% of the seeds that are generated by the plants, they are eaten by birds. And the 50% of rainfall that is occurring in this world is in the oceans. So if you look at this very closely, there is one thing that is very sure in our nature, that is called as law of wasted effort. I read it very recently and I found this is very applicable to it. Why? Because in this whole universe, we, the human beings, we feel that when we don't give, when we fail in our attempt, we feel that we feel so much amount of depression. But when you compare to other animals, when you compare to other living beings around you, there is nothing like that. You fail. That doesn't mean that's the end of the life. We feel bad. I do accept it. I also feel bad when I don't achieve it. But you need to understand that this is not the final examination, what you are going to write. That what is going to decide your fate. From this examination, what are the inputs what you have gained, or have you identified your mistakes, where it has went wrong? You might have expected a rank of 1000, less than 1000, but you landed up on a rank of 5000. What is the mistake you have made? Might be the mistake is in your time management, might be the mistake is in your revision strategy, might be the mistake in the amount of questions you are attempting, Some students, they say like, they attempted all questions, or they attempted very less questions, or more negative marks they are creating, right? So, or might be, there are so many factors. I can't generalize all factors, and I can't tell you that this is the factor that has reduced. It is your job after writing your examination. Every time I tell to all students that after writing your examination, after you have given this INISET exam, any sort of examination, the examination is not over. Come down to your house, take a good nap, take out the paper and try to recollect all the questions. At that moment only, you will come to know how many questions you have attempted properly. How many questions you have attempted properly. So this is what I generally say to the students. Okay, so most of us, what we do is, after writing examination, we just get relaxed. We eat, we drink, we sleep. That's it at the end of the day. No, that's not the over. So next time what you try to do is, after writing the examination, try to recollect the question. Because what will happen, we humans have a very bad tendency of forgetting our own mistakes. We dwell that, arey yaar, we have not got the seat. We have not achieved the mark what we have made, but we are not concentrating where we need to concentrate. What is the mistake that has happened in this examination? And how can I correct? If you can identify your mistake, then in the coming examination, you will come out with a flying colors. This is what I wanted to say in this examination. So most, like as students say, lack of success, failure, not trying. So most of the times we think lack of success is not equal to failure. It is, failure means it is not trying. So don't get depressed by this rank. Take it as a challenge. Take it as a lesson where you have gone wrong, and try to improvise on that, rather than thinking like yaar mera kuch bhi nahi hota hai, I can't do anything here. Right? So don't think like that. Be positive, try to gain more amount, because at this moment we don't have anything, like we are in such a dilemmatic situation that still our examination date is not yet announced. So if you are depressed, you feel yaar ye exam kab hoga, like you might be thinking like, when we will get this examination, when we will come out of this hell, this shitty thing where we are preparing whole day in day out. So when you are in depressed mode, you think like this. But when you are in a positive mode, you think only one thing: you have some amount of time to identify your weak areas and to improvise on those areas. So this is what that makes the difference in a student who comes out with successful flying covers in the next examination. That is not next examination, in the forthcoming examinations. Right? So this is what I wanted to say is, don't feel depressed. It's not about you. You need to identify your weak points. So the whole attitude that depends is, now you might be on a third stage, but if you have a positive attitude, you make it like 2 + 1 = 3, and in the next coming examination, you might be coming on to the first stage. Okay, so please develop the positive attitude. Don't get in a depressed mood saying that examination date is not announced, or something is going around you, you are feeling sick, you are feeling low. No, keep all these aside, because we have a bigger target in front of us. So please concentrate on it. The second thing which most of the students, they ask me is, what is the strategy to prepare? There is only simple strategy if you ask me. That is, revise, practice, repeat. My strategy is very simple. Revise, revise, revise. Sir, what to revise? So if I am at your position, what I will do, I am very specifically saying, if I am at your position, I am not at your position, but my statements applies to me only. That is very clear to me. So many students, they ask me a very simple question: sir, how to prepare? How to prepare? How to use this time? How to use this time? I will say a very simple thing. You can't ask me, because I am not writing the examination. Everyone is unique in their own preparation. Everyone is unique in their own preparation. How can, most of the students, they fail because they want to copy it from a topper. They want to copy it from a faculty. My approach to a subject is entirely different from your approach to a subject. How I look at the things and how I perceive the things are very, very different. So rather than asking any faculty. I might be a faculty for you, but when it comes to tell you how to prepare the subject, I would act as a position, I would take the position of a mentor. What does a mentor do? Mentor says he will not tell the preparation strategy. He will not tell the preparation strategy. I personally feel it's waste for me to tell you my preparation strategy, because I can read whole physiology in a day. I can read whole pharmacology in a day. I might take anatomy 1 month for me to read. So, that's what, this is the difference. You might be good at anatomy. So, you can't compare my strategy with your strategy. So, every time I tell to the students is, rather than asking me or any faculty or any of the topper students or any of your friends asking their strategy, tell them your plan. What's your plan? And a good mentor or a good faculty of any faculty in our team also, they will tell you what is right or what is wrong. Because if I start telling you my plan, I am not going to write your examination. So obviously it doesn't work for you. So like last time when one student has asked me, sir, I want to write GT every third weekly, I don't want to write all GTs. Then I said, it's fine. How do you want to prepare? Because you might be seeing so many interviews of the toppers. Some students say GTs have helped. Some students have said GTs have not helped. It's their own perception of the things. So my suggestion at the end of the day is, you make your realistic plan. You make your realistic plan and you try to achieve that realistic plan in a daily fashion. Once you have achieved the daily plan, try to increase that realistic plan. Try to increase that realistic plan. This will help you. This will help you rather than asking me, sir, how many days to prepare or how many GTs to write. So finally, one word to conclude this session is, be positive. Try to improvise your skills. Try to identify your weak areas. Try to improvise these weak areas, because you have got a good time to improvise rather than feeling slogged or feeling bored, like what to prepare or these things. There will be so many things which you need to cover. When I say so many things which you need to cover, don't take out and jump and take out the new things and try to read it. Try to revise more, because what has been proved consistently in all these years in all the students who have secured the rank is revising. And I personally feel like when I am at your place, what I do is I write more MCQs, because I personally feel writing more MCQs would give me a better edge, because my weak point is I do commit mistakes very frequently. Might be because of my silly mistakes. When I write an competitive examination, I found out I do commit silly mistakes. I don't read the question properly. These are my weak areas. So what I do here is I will try to improvise by doing more amount of GTs. But as I said it doesn't mean that everyone should have the same thing. I do as a general rule, as I have seen so many interviews of all the students, they say writing GTs is very helpful. Most of the students, they agree to this fact. Every week they have to write. That's my wish. I don't know whether you guys will accept it or not. If I am at your position, I will write minimum 2 to 3 GTs per week. That's my strategy, because as I said my weak area, right? So the third thing which I say is, be positive in this whole pandemic season or whole changing season. So try to be more productive rather than dwelling on the things which you can't control, like how is the examination pattern or what is going to happen in this coming examination. Will they put the NEET examination? One thing is very clear, that they are going to ask something which is related to medicine only. They are not going to ask you something related to economics or politics, right? So don't look at all those things. Try to do more amount of clinical MCQ related questions and try to give your best. So this is what I wanted to say at the end of the day. So best of luck from my side. Hope you come out with your flying colors in the forthcoming examination. Thank you all.